next presentation is by Lize. Lize is one of the doctors working in Rotterdam, and she's already working there for a long time. So I'm really pleased she's doing her contribution. And well, welcome to you, Lize. And last but not least, I would like to say, so the floor is yours.
Yeah, good afternoon, and thanks for sticking around after this wonderful set of talks. I'm happy to close off the European session with a presentation about cognitive markers of FTD. A short outline of my talk today. I will give you a short introduction about what a neuropsychological assessment is and a typical cognitive profile of FTD. I also want to discuss memory problems in FTD, as they are, in contrary to what sometimes is believed, an integral part of the cognitive spectrum. Then I will focus on gene-specific cognitive profiles we often see in familial FTD, patterns that already have become apparent in the pre-symptomatic stage. And lastly, as we're moving towards clinical trials for FTD, choosing appropriate cognitive endpoints is of utmost importance, but very challenging for a heterogeneous disease as FTD. And I will be closing today with, in my opinion, potential candidate markers of cognition. But first, a brief introduction about a neuropsychological assessment. A neuropsychological assessment, or NPA, is the systematic evaluation of the brain-behavior relationship in an individual patient. And although the administration and scoring of the tests and screening tools takes up a big part of the neuropsychological assessment, it's more than that. It also includes careful history taking, including the assessment of cognitive, behavioral, and psychological changes, as well as taking personal and contextual circumstances into account. It also includes the evaluation of the patient's mental status and capabilities by means of careful observation. Typically, a neuropsychological assessment takes several cognitive domains into account, including tests for language, memory, attention, mental processing speed, executive function, and visual spatial abilities. An extensive or comprehensive neuropsychological assessment is an essential diagnostic element when it comes to dementia diagnosis. It can aid in diagnosis and differential diagnosis, but also help in monitoring and quantify cognitive and behavioral changes over time. And lastly, it can aid in psychoeducation, as in informing and advising patient and its system about how cognitive changes relate to the daily functioning of the patient. When we zoom in on the current diagnostic criteria of behavioral variant FTD, we find the neuropsychological assessment in section F. It states that the cognitive profile is characterized by executive or generation deficits, with a relative sparing of episodic memory and visual spatial functions. In clinical practice, we see that next to executive dysfunction, prominent deficits in language and speech, as well as social cognition, are the cognitive hallmark of FTD. And I will be going into these domains next. First, executive function, also known as the control chamber of the brain, or the flight control deck of an airport, if you will. In neuropsychological terms, it encompasses a set of complex cognitive processes necessary for the control of behavior, including working memory, planning, prioritizing and organizing, inhibition and self-control, reasoning and problem solving, and mental flexibility. On the behavioral level, as a result of executive dysfunction, FTD patients will develop problems with emotional and impulse control, initiating and monitoring their actions, and flexible thinking and shifting when things don't go as planned. Language and speech deficits are not part of the current diagnostic criteria for behavioral variant FTD, apart from stereotypy of speech, which is considered to be a behavioral symptom. Stereotypical speech can include single words, phrases, or entire themes or stories that the patient repeats despite their lack of communicative value. And as the disease progresses, more and more language and speech deficit become apparent. including naming deficits, for instance, of nouns and verbs, single word comprehension deficits. Patients tend to make semantic errors and have a less prepositional or intentional speech, and they develop problems with grammar. And in late stages, most patients become mute. I hope this video is going to work because the connection has been a bit sketchy today. So we'll try to show you the video of a patient, an FTD patient with severe language problems. And I hope the video works, but it's in Dutch. My apologies for that. For the non-Dutch listeners, I've attempted to put an English translation on the right side, so we can always fall back to that if the video is not working. I will give it a try. Oh, sorry.
Ja, doe ik ook niet, maar mijn man wel. Uw man doet hem wel. Wat doet hij dan? Nou, bij gedeelte, ja. Een beetje een gedeelte, ja. Dan kan je gewoon hier een gedeelte. En dan heb je de ene kant heb je nog de ene kant. Ja. Ja.
Ga ik u wat mogelijkheden geven? Is het een hamer, een zaag of een schroevendraaier?
Schroevendraaier niet.
Nee. Een hamer, een zaag.
Het is heel verstoord, Lize.
Yeah, so I will just give a brief summary. This patient has severe naming and single word comprehension deficits. This is the Boston naming test, a naming test for semantic knowledge. This patient does recognize the object, the saw, but is unable to give a comprehensive description of what it is or what it does. And her speech has also become cumbersome and rather empty. Lastly, deficits in social cognition. And social cognition, as was already referred to today, is a set of cognitive processes underlying the ability to understand others' intentions and behaviors in order to plan actions accordingly. And social cognition can be conceptualized along three hierarchical levels. The first level is the level of perception and automatic attribution. And it includes facial emotion recognition and reading body language. The second level is understanding and interpreting social information. It includes empathy, understanding social faux pas, and understanding humor and sarcasm. The third level includes reasoning and regulating, and has to do with moral reasoning and decision making, so deciding between right and wrong, and for instance also error monitoring. And we see that FTD patients are affected at every level of social cognition in early disease stages. For instance, on the first level, we see that patients have trouble recognizing emotions, and especially negative emotions. On the second level, we see trouble in recognizing social faux pas. And this is from one of the tests you can administer. It's a comic about Jill that just moved into her new flat, and her friend Lisa came over. And Lisa is commenting on the curtains that apparently Jill bought, and that she really hates them, and she hopes that Jill is going to buy some new ones. And what you see is that FTD patients have trouble understanding not only what goes wrong in this particular situation, but also to understand how Jill and also Lisa must have felt. On the third level, we see problems in moral reasoning. And this can be tested by, for instance, the trolley dilemma, in which the patient has to choose between diverting the tram from the main track it's on, thereby saving 5 people on the track, but jeopardizing one person on the other track. So you see that patients have trouble understanding and deciding between what's right and wrong. Then memory deficits as part of the FTD spectrum. And it's a common misconception that memory deficits are not part of that spectrum. And that's partly related to the fact that in the current diagnostic criteria for FTD, it states that episodic memory is relatively spared. but it only states that it's relatively preserved in comparison to the executive dysfunction, which is not the same as not being affected at all. It is also sometimes believed that low memory scores on a neuropsychological assessment are related to executive dysfunction, for instance, defective storing and retrieval strategies, and should not be considered a true amnesia per se. In a recent meta-analysis, we discovered that memory deficits are indeed part of the FTD spectrum in comparison to Alzheimer's disease patients and controls, and I will show you the results now. On the left-hand side, you see the comparison between FTD patients and control subjects. And listed here are all the studies that looked into memory performance in FTD. What can be observed is that FTD patients overall tend to perform worse than control subjects. When you compare FTD patients to Alzheimer's disease patients, although you see that FTD patients in general tend to perform slightly better than Alzheimer's disease patients, this is not the case in all situations, as can be depicted here. And actually that FTD patients perform at the intermediate level between the control subjects and patients with AD. This shows that in clinical practice, based on memory measurements alone, it can be very difficult to distinguish between FTD and Alzheimer's disease patients. Now over to the cognitive profiles in familial FTD. As you might have heard today, FTD tends to be highly genetic, with up to 40% of cases being explained by dominant mutations in one of the genes. The most common mutations can be found in the MAPT, progranulin, and C9 genes. And we already knew that the different gene mutations were leading to different clinical phenotypes. But a recent study also showed different cognitive profiles depending on the mutation involved. For instance, deficit in memory and naming in MAPT mutation carriers, whereas progranulin carriers were characterized by attention and executive function deficits. In C9, we see a different cognitive profile. In general, more cognitive domains are jeopardized, are involved, so a global cognitive pattern of deficits, but patients also tend to be less affected, so it's a milder cognitive profile as well. We see the field move more and more towards the pre-symptomatic phase. That is the phase in which there are no overt symptoms of disease yet, but the underlying pathology is already active. This is a very interesting stage, as the pathological damage is still mild and potentially also still reversible, which makes it a very important phase for early diagnosis setting and the start of disease-modifying treatments in trials. In my previous research, I looked into pre-symptomatic cognitive decline in MAPT and progranulin carriers as compared to controls. Not only did we find that pre-symptomatic cognitive decline is present in the pre-symptomatic stage, up to 8 years prior to estimated onset, but also that we already in the pre-symptomatic stages saw a gene-specific pattern of decline with language, social cognition, and memory deficits in MAPT, and also memory deficits in progranulin carriers, which also basically confirms the fact that memory is affected in FTD and already in the pre-symptomatic stages. Follow-up work within the same cohort looked into cognitive decline in the last few years prior to conversion to the symptomatic phase. So pre-symptomatic mutation carriers that develop symptoms of FTD. And what you see here on the x-axis is the years before symptom onset. So 4 years before, 2 years before, and here the 0 mark is the conversion point. And what can be observed is in that, especially in the last 2 years prior to conversion, as you can see here in the large drops here, the biggest cognitive decline is visible in the last 2 years. And again, gene-specific patterns can be found. Again, language, social cognition, and especially memory, as you can see here in MAPT, are jeopardized right before symptom onset, whereas attention and executive function are more affected in progranulin. The likely additional explanation is that cognitive decline is present earlier, but our current traditional neuropsychological measures are simply not sensitive enough to identify the small incremental changes happening in the pre-symptomatic stage of FTD. This leads us to the following hypothetical model of a familial FTD. Within the pre-symptomatic stages, a slight cognitive or clinical decline that rapidly increases here in the symptomatic stage. And this mid-stage or transitional stage, if you will, is a very interesting phase in FTD, with a lot of rapid changes happening in the last 2 years prior to conversion to the symptomatic stage. As we're moving towards clinical trials, I believe that measures of cognition will remain the central marker of change and clinical benefit, in addition to neuroimaging and biofluid markers such as NFL. Only the biggest problem we are currently facing with respect to these cognitive markers is that the traditional instruments we are using are not likely suitable enough for the pre-symptomatic to early stages of FTD. For instance, a number of tests, including the MMC or ADAS-Cog battery, lack domains that are specifically abnormal in FTD, such as executive function. Other tests lack adequate sensitivity to measure the small magnitudes of change that are happening in the pre-symptomatic to early disease stages. Others have a very coarse metric, for instance, only pass versus fail, or a very small range of possible answers, so that the construct they are trying to cover is not really adequately covered. And lastly, a number of tests are not really suitable for repeated administration, especially not in the pre-symptomatic stage, as they are very susceptible to practice and familiarity effects. In the last part of my presentation, I would like to discuss a couple of markers that are, in my opinion, good candidates for future trials. First, the use of more ecologically valid tests. That means tests that resemble the real world as much as possible. In an earlier part of the presentation, I already showed you the Ekman Faces test. And you might see that these photos are very old. I think they are made in the 60s. And they also show very extreme emotions and in a very static way. And I hope you agree with me that real life emotions generally don't really look like that. They're often much more subtle. And by using these tests, you might miss more subtle deficits in emotion recognition. For that reason, Roy Kessels developed the emotion recognition test, or the ERT, in which he looked into the recognition of the basic emotions, but across different emotional intensities, ranging from 0%, so more neutral phase, to 40, 60, 80, and here's the extreme, 100%. And what makes the ERT a very interesting candidate is that in my recent work, I showed that early symptomatic FTD patients, depicted here in dark green, so those are the mutation carriers that have just converted to the symptomatic stage, they already show deficits in emotion recognition by means of the ERT. And they score right in between the healthy controls here in dark blue and the symptomatic FTD patients. So it's a very sensitive instrument. And that can also be seen when we look into pre-symptomatic mutation carriers of the FTD genes. And it becomes apparent that especially at the lower emotional intensity, so here at 40%, C9orf carriers already show minor deficits in emotion recognition. So that's even before they develop symptoms. And all in all, this makes the ERT a very interesting candidate for early and pre-symptomatic FTD stages, and potentially also for clinical trials. Another interesting approach is trying to quantify the subtle and the often qualitative changes we observe in behavior and language when we see patients in clinic. In language, for instance, we would like to investigate more qualitative aspects of speech, including rate, latency, and also prosody. And an interesting study by Naomi Neffler from Murray Grossman's group in Philadelphia showed lower prosody, so that's the emotional timbre in spontaneous speech, if you will. She showed lower prosody in FTD patients as compared to controls. So basically, it means that the spontaneous speech of FTD patients becomes more metonymous. And that's also something that we observe when we see patients in clinic. Lastly, within the GEMFI cohort, we are currently looking into the benefit of using cognitive composites on reducing the sample sizes for future clinical trials. Interestingly, it was found that sample sizes can indeed be significantly decreased by using a composite instead of individual test scores, but also that an ideal cognitive composites battery most likely consists of a number of similar, for instance, attention and emotion recognition paradigms, but also unique tests depending on the gene mutation involved. So in MAPT, it would be good to use tests for semantics and naming and memory, whereas in progranulin, for instance, it would be best to use tests for executive function. So to summarize this all, the traditional cognitive profile of FTD is characterized by deficits in language and speech, executive function, and social cognition. And in contrary to what sometimes is believed, memory is often affected as well. Looking at familial FTD, we see gene-specific cognitive profiles that are already visible in the pre-symptomatic to early disease stages. And lastly, the development and the application of good cognitive endpoints is of critical importance to the success of upcoming clinical trials. In order to capture these changes, we need sensitive, ecologically valid instruments that are able to capture these small and often qualitative changes, as well as gene-specific changes happening in the pre-symptomatic to early symptomatic stages. I would like to thank my collaborators in both Rotterdam, London, Leiden, and Amsterdam. But above all, I would like to thank all the patients and the study participants and their families for dedicating their time and energy to our research. Thank you.